Hey everyone, it's Dr. Anthony Kaveh, and I had a patient just yesterday, this macho guy, really big, burly. And the second I walked out of the room after I interviewed him before surgery, he said, Doc, psst, come back, come back. So I look over my shoulder and I'm like, yeah, what's going on, sir? And he makes sure no one else is there. And all of a sudden, his eyes got wide, wide open. He said, Doc, what'll you do if I wake up in the middle of surgery? So, this is a really common question that I get asked, and it's really serious because the consequences can be profound psychologically and physically if you wake up in surgery. Here is what doctors should do if this happens. And if you're a patient, you should know what to expect so that you minimize the risk of a bad outcome happening. So, you first have to recognize that doctors and patients can have similar reactions when this happens. If the patient literally freaks out because, oh my gosh, I hear what's going on or I feel what's going on, the doctor may emulate that. If the doctor emulates that, whether it's under sedation with a mask or under general anesthesia with a breathing tube like this one, that might transfer onto the patient. And this has been studied in, believe it or not, sham surgery studies and trials where they have patients go under anesthesia and then they have fake emergencies or nothing happening. In those patients that were under anesthesia and there was a fake trauma being played out, some of those patients woke up saying, I had a weird feeling that there was an emergency going on. This wasn't real surgery. This was to see how aware is the brain, even when it's under general anesthesia. So the mood that doctors have is contagious in a sense, not unlike infectious disease, not unlike obesity, not unlike anxiety or depression. Our moods influence patients under anesthesia, especially if they're in that very delicate or vulnerable period when they might be a little awake. Now, for those of you who are thinking, oh my gosh, am I going to wake up in surgery? Remember that it's like 1 in 1,000 surgeries, and it's likely lower than that for routine elective surgeries. There are some outliers, individuals that smoke weed or pot every day. They have higher anesthesia requirements, as do chronic alcoholics. The more anesthesia you need, theoretically, the higher the risk of being underdosed anesthesia, and you might therefore have some awareness. The first thing, in addition to the contagion effect, is that when you're under anesthesia, you're kind of like a child because children are both highly impressionable and heavily disinhibited. Our inner self is also heavily impressionable and disinhibited. When you're under anesthesia, you are disinhibited because you have all sorts of drugs in your body and impressionable. Very, very serious here. This is why medical hypnosis or clinical hypnosis can be augmented under anesthesia for positive outcomes. I have a whole bunch of videos on that. We won't talk about that today, but the influenceable part can be used for good. So that if a patient does have some awareness, you can impart something positive on there. All right. That's the mainstay of how doctors need to treat patients in the moment quickly when awareness happens. But you also have to recognize that there's 3 parts, and this is really the framework that everyone should take away. There's a pre-surgery, intra-surgery, and post-surgery way of treating this. And before we launch into that, just as a shout out, if you appreciate me coming on after a long day in the operating room, I greatly appreciate you sharing below your comments about what you've learned. Have you ever been aware under anesthesia? And if you could hit that like button and share with others to empower others with this medical knowledge, it would really support me doing this more often. As you know, I don't like to do any product placements because I just want you to know how much power you have over your inner healing potential, even under anesthesia. So pre, intra, and post. Remember that before surgery ever happens, your doctor needs to talk to you so that you can hear their voice, so that you can be, you can know who is going to be in the room in control of your consciousness and your brain and body under anesthesia. But the same goes for patients in my ketamine infusion clinic. I speak with them really in depth before because the same premise holds. You'll see for psychedelic experiences, for anesthesia, and even for your sleep every night. And we'll get to that in a moment. But you need to know who your doctor is, have to ask your questions so you are confident that they are the right doctor for you, that you trust them with your life and consciousness. That's the setup. You need to do that first. It's why I call my patients the night before surgery. Next, in surgery, when the patient wakes up, you have two things you have to immediately address. Number one is this a surgical emergency? Do I need to immediately just slam IV anesthetic to put the patient down, maybe paralyze them so they don't accidentally move? Or do I have a couple of seconds to reassure the patient to calm them down so they don't move and accidentally hurt themselves or someone on the surgery team? So we had to break this down. If you're under general anesthesia and you are having, for example, an intrathoracic surgery or an intra-abdominal surgery, these are delicate surgeries. If you are a little bit awake and you might move, you might hurt yourself or others. You'll probably have a breathing tube down your mouth. We need to immediately push an IV medication because that's the fastest way to go from medication to your brain. And that has to be done for safety. There's no question there. However, far more often, I'm having patients who are having sedation, like with a mask, who are not paralyzed, not under general anesthesia. There's no breathing tube. It's just a mask. And they might be in this twilight zone and they kind of perk up out of the twilight zone. And it can be scary if that happens. That is when, if it's not surgical emergency status, here is the crux of everything. Connection. I know it sounds kind of silly, right? But if you can connect with somebody under the influence of anesthesia who is approaching a traumatic state, I find it to be incredibly powerful. You can give more medication as well. That's fine. But giving more medication may not address what awareness has already occurred. Rather, you need to both give the medication and assure the patient through a connection, often, and these are my tricks, often with both voice and touch in the appropriate patient. If it's a woman, in particular, I'll ask a female, other individual in the room, whoever it is, to maybe help out because I don't want to obviously induce any unpleasant or unexpected. I don't want to seed their subconscious with that in this vulnerable state. Safe places are to put hands on the forehead, on a joint like the shoulder, on the elbow, on the knee, the foot, ankle. Usually a joint is safer. It's less startling, especially in that vulnerable state. Depending on what part of the body the anesthesiologist has access to, that's where we need to put a hand, connect physically. Then the words that I always assure a patient as they're falling asleep, so it's the last thing they hear me saying, I repeat them. It's not like a mantra per se, but it is rather something that they are familiar with, from a voice that they are familiar with, whom they trust, who they have connected with before surgery. Those words tend to include things like, you're safe with Dr. Kaveh. The surgery is going very well. We're not losing any blood. You're going to wake up safe and warm and comfortable. Let your arms get heavy. Let them fall by your side. You're safe with Dr. Kaveh. The surgery is going very well. Of course, it has to be context appropriate, but let them calm themselves down. If they start to move their hands, yes, you can always brace the arms down. And sometimes in emergency situations, we need to do that. But recognize that if you can get the patient to do it out of their own volition, just how much more comfort and confidence are you instilling, imparting? You already had the physical touch going. The forehead is a great place, by the way. It does. I actually learned this from women having cesarean sections because they would sometimes, have some shock, emotional shock when everything is going on. I put my hand on the forehead and then speak to them. And of course, once again, you have to be appropriate to the patient. If it's someone who has a history of, God forbid, a sexual abuse or some other terrible event, then it might not be appropriate. You need to know your patient. But you got two modes of connection there, and you want the patient to calm themselves down. You can always push medication, but it's not going to necessarily cover up the awareness that may have already occurred. The more safe you can make the environment, the lesser the risk of this turning into PTSD in the future. So, like we said at the beginning, it's like a child, right? You can always manhold a child, I suppose, but is that going to impart a positive emotion to the child, especially in a vulnerable time? Probably not. The inner self is like a child. It is impressionable based on what you say to it, and it is that was my bedtime alarm coming up. It is both impressionable and it is disinhibited. The child can't regulate their emotions. Well, your inner self, especially under anesthesia, can't well regulate its emotions. So that's why you need to, as a physician, you need to impart that level of confidence, trust, comfort, safety. And if that's why the pre-surgery is important. This is what you do intra-op and now post-op. You got to debrief the patient. You have to debrief a patient because, and this is key, if patients don't know that they had this traumatic experience because their memories were kind of wiped, they might have PTSD symptoms for weeks, months, years to come and not be able to piece together in their brain why this happened. And if they can't piece together in their brain why they happened, boy, it's going to be tough for the doctor that they talk to later on to figure out what was the source of this PTSD. Most doctors have no clue that this can be a real legitimate cause. Not that they're dumb, but because it's so rare, fortunately, with modern anesthetics to have awareness. It often goes undiagnosed. However, because the body keeps score, the whole mind body connection, which is so real under anesthesia, very, very real, even minor awareness episodes, like maybe just feeling something in a patient who's susceptible because they've had some sort of sexual abuse in the past when they have not been in control of their body. Maybe hearing something that is a trigger from a combat vet who heard all sorts of explosive devices. If they hear a drill during surgery, maybe they weren't fully awake, but their brain processed some sort of sound that triggered a past event. You can imagine any number of permutations like this. And even if it's a subtle awareness, there is a risk that it might turn into a traumatic experience that the patient will never know to extrapolate back to that surgery because they don't have the memories fully intact, which is why you need to debrief with the patient right there and then. Did you feel something, sir? Was anything uncomfortable for you? Did you hear anything that was alarming to you? Did you see anything that was frightening to you? Did you feel comfortable and safe throughout? Were you ever in pain or uncomfortable? It takes like 25 seconds. It's so easy to do, but you got to do it. You can't just drop off the patient in recovery and zoom on to the next patient. I mean, of course, sometimes hospital, because we work in a broken medical care system, and it is a pill mill slash meatpacking factory, but the doctor has to take that brief pause, literally 20, those questions. Was it even 25 seconds? No, not even. There's no substitute for presence and human connection, especially in the most vulnerable moments that our patients are in the operating room. There is no substitute. It's like raising a child with television. Could you imagine? It's like you can't let a child just, live their whole lives learning from a TV. You got to be present and connected with them to help guide them. So that's the case in surgery. It's the case when patients come to me for ketamine infusions for depression, anxiety, PTSD, or chronic pain, the same level of guidance throughout. And heck, when you go to sleep at night, if you're in the right mindset before your sleep, you're comfortable, the temperature is right, your mind is at ease, you're not anxious about the next day. Aren't these all things that promote restorative sleep and hopefully positive dreams? Versus going to sleep feeling totally afraid of like, oh my gosh, what if someone like gets a Sharpie and puts a mustache on me? Silly example, I know, but you get the idea. Oh, Katie, thank you for that super thanks. And we'll answer your question in just a moment, Katie. But that if you fall asleep anxious, that's going to impact your sleep. You might have nightmares. It's the same pre going to sleep. You have to be in the right sincere intention Sincere intention is so powerful before surgery, sleep, and psychedelic experiences. And then your compassion during the surgery itself, if you're the doctor to the patient, or if you're the one struggling with the sleep or in that psychedelic experience, self-compassion, there's no substitute for this. Compassion for yourself. I owe myself this sleep. If you have ruminating thoughts running, do you have the self-compassion to say, you know what? I am worth more than these thoughts that are racing throughout my brain. It's so similar to the doctor that can give that compassion to the patient, that like, hand on the forehead. Ma'am, sir, you are safe. Dr. Kaveh is here caring for you, or whatever the doctor's name is. It could be anyone, not me. That level of compassion. It's sincerity before and compassion in the moment. Sleep, psychedelic experiences, and anesthesia. To answer Katie's question, can you dream under general anesthesia? You can. It's not very common. I'm going to share it with everyone what you shared here. It's quite deep. I saw my late husband, and he told me to go back. I have heard experiences like this from many patients, seeing ancestors, seeing loved ones, past or present. I hear it more in psychedelic experiences, but especially ketamine. I don't know the significance of these. I'm not going to pretend to know the significance any more than I can know the significance of dreams in individuals who I don't know more about. But many individuals do find healing from experiences, Katie, like what you shared. Uh, Really powerful observation. I hope everyone here appreciates Katie's vulnerability in sharing something that deep. Most patients are afraid to ever even ask me about, can you dream under anesthesia, much less share what their dreams are like in that very vulnerable moment. So thank you so much again, Katie. I hope everyone here learned something new. Please share what you've learned with others to help empower others to advocate for themselves in this broken healthcare system that we all live in. You have more power to control your health than you've probably ever been told. And I hope you all learned one more thing today. Take control over that inner healing potential that we're all, nearly all, born with. Until next time.